From Addiction to Recovery, for a new tomorrow and a new you, brought to you by Blue Ridge Family Practice. I'm Raymond Owenbrink, a board-certified addiction medicine specialist, and I'm here to help you understand and adapt to and recover from the disease of addiction. The first parts of this presentation pertain to the science behind the disease of addiction. You may wish to skip over this or briefly skim it and then review later if you would like a more detailed understanding of the disease nature of this condition. This in-depth review of the science of addiction was done to clearly describe that addiction is truly a disease in every sense of the word. We'll show that addiction is truly a genetically transmitted disease. We'll also show how you can adapt to live a better life than you ever imagined with this condition. U.S. prevalence of illicit drug use and abuse during 2015. There's a 41% incidence of any illicit drug use over somebody's lifetime in the United States. Admittedly, 41% can include one-time use of a substance, which is hardly addiction. There's an 8.5 incidence of any use of illicit drug in the past month, however. Monthly use is much more regular use than use in the past year or lifetime. This information is obtained from surveys. Survey data often underestimates actual use. Minimizing use is common among addicts. Minimizing is a form of denial. Considering the above, it's quite possible that up to 10% or more of the population may have a problem with substance abuse, excluding tobacco. A review of the table shows that alcohol abuse runs at about 14% of the population this past year. Looking at amphetamine, benzodiazepine, barbiturates abuse, cocaine abuse, 2% of the population in the past year, or almost 1% using it on a regular basis. Ecstasy is a drug that's not used quite as frequently. Hallucinogens are used almost as frequently, but they tend not to be as addicting. Heroin use is also noted to be a fairly significant number when one multiplies it out by the population of the United States. Inhalants include huffing, organic solvents such as gasoline, paint thinner, nail polish removal. It causes a lot of brain damage as well. Ketamine is a dissociative anesthetic used in veterinary and human medicine. It causes a fugue or trance-like state. Marijuana abuse, over the course of the lifetime, at least a quarter of the population admits to trying it, and over 10% of them have used it in the past year. Methamphetamine is a stimulant that is very easily manufactured. It's inexpensive. In the past year, 5% of the population has used it. In the past month, 2%. They're using it regularly. Opiates other than heroin, the pain pills, 4% in the past year of use. This is not the therapeutic use. This is abuse of this class of medication. In the past month, 0.1% of the population admits to abuse of this class of drug. Remember, this is not taken as directed. This is recreational or addictive abuse. When one considers the scale of the use of psychoactive substances currently in the United States and considers that addiction is often characterized by the abuse of multiple substances, there is clear cause for concern. Generally, folks don't use only cocaine or only benzodiazepines or only opiates. They use all of these drugs in combination. Abuse of illicit substances costs the United States over $193 billion annually. Total substance abuse, including alcohol and tobacco, costs over $700 billion a year. These costs are attributed to time out of work, care for overdose and other problems, people harmed by those under the influence, property damage caused by those under the influence, and other factors. Addiction is a disease. Our biology programs us to seek pleasure. Addiction is a disease of self-will run riot. Spiritual and social growth and maturation teach us to look out for the needs of others. This inherent conflict between good for us versus good for others is a bit like good versus evil that has plagued mankind since Adam and Eve. Addiction involves multiple human domains. Biology, medicine, of course, is the art of applied biology. Psychology, sociology, spirituality, together they form the biopsychosocial spiritual, or BPSS, approach to the disease of addiction. Addiction can happen in many forms. Substances such as alcohol, drugs, food, behaviors, gambling, love and codependence, sex. The American Society for Addiction Medicine, ASAM, points that genetics contribute 50% of this chronic brain disease. Genes load the gun, and environmental exposure or using pulls the trigger. Nobody can choose their genetic makeup. We couldn't pick better parents and genes. Addiction treatment provides education that helps people to understand and accept their genetic predisposition. Recovery consists of recognizing and understanding one's genetic vulnerability and adapting their life to grow beyond the constraints of this disease. Homeostasis is the term used to refer to the tendency toward a relatively stable equilibrium between interdependent elements, especially as maintained by physiologic processes. If something happens in one area, a corresponding change to balance the new system will happen elsewhere. Everyone has their own unique normal balance. Communication is essential to health. Our brain is constantly communicating externally with the senses of sight, smell, taste, hearing, touch, voice. Internally, our brain communicates through nerve cells called neurons that connect different areas of the brain to one another. Brain biology, how nerves in the brain work. Neurons have their own components. Dendrites receive information from other neurons. Axons transmit information to other neurons. Usually the cell body, where the nucleus and metabolic apparatus of the cell is located, will be between the dendrite and the axons. The action potential is the term used to describe the electrical transmission down the nerve. This is a brief reversal of the normal internal negative voltage of the cell, created by the passage of positively charged sodium ions into the cell as gates or pores open. The synapse is a tiny gap separating neurons. Chemical neurotransmitters cross that gap to communicate to the next neuron. These neurotransmitters are stored in vesicles. You can think of small water balloons at the tip of each axon. An action potential, this electrical depolarization reversal of the normal negative internal voltage, propagates in a wave-like manner along the neuron. When it reaches the end of the axon, it triggers the release of the neurotransmitters into the synapse from the vesicles. Neurotransmitters that are released into the synapse, the link here, if you click on it on the PowerPoint or on the outline that's on the website, will show a YouTube video of what this looks like as receptors for each different type of neurotransmitter present to the next neuron. Neurotransmitters present to the receptors on the next neuron. There are systems to recover or reuptake and recycle these neurotransmitters once they get to the next neuron. The neurotransmitter drug recovery sometimes happens on both the presynaptic and postsynaptic sides of the synapse. Drugs can have the same effect or different effect. Drugs can mimic a neurotransmitter, acting as an agonist, producing the same effect. Drugs can also block a neurotransmitter as an antagonist by occupying a receptor without causing this expected effect. This means that the proper neurotransmitter can't occupy the receptor to trigger its normal function. These neurotransmitters or drugs, when they reach the next neuron, they can actually speed up the reuptake, shortening the effect of the neurotransmitter, or slow the reuptake, which would lengthen the effect of the neurotransmitter on the next cell. Binding to the receptor is rarely, if ever, permanent. There's a term that we call affinity, which is used to measure the strength of the neurotransmitter drug receptor binding. High affinity means that the bond is stronger and will last longer. This is not the same as the term half-life, which relates to how long the drug will be in the body. Half-life is determined by a variety of different factors. Absorption, typically through the gut for swallowed drugs, or through the lungs, nose for smoked and snorted drugs, etc., into the bloodstream. Distribution refers to the distribution of the drug throughout the body, where the drug will go within the body. The rate of metabolism, which is chemical decomposition or breakdown, generally occurs in the liver, but can occur in other organs as well. Also, the concept of biotransformation, which takes the original chemical drug, neurotransmitter, and reduces it, changes it to other metabolites which may or may not have biological activity and effects on receptors on other parts of the body or on the intended original parts of the body. Finally, we come to excretion, usually through the kidneys, sometimes through stool, breathing, and sweat, is how the drug and the metabolites of the drug are removed from the body. Receptors can also have different effects. Some receptors might trigger another action potential, depolarizing, triggering the next neuron to send another action potential down the next cell's axon. Sometimes they will open ion channels on the cell membrane locally to hyperpolarize and reduce the possibility of another action potential forming in the next neuron. The net result is basically what happens when numerous axons from different neurons in different parts of the brain connect to a given neuron. We'll call it the next neuron. And the end result of what happens on that next neuron will be the net effect of all the various axons from other parts of the brain interacting, some hyperpolarizing, some trying to depolarize, on whether or not an action potential will propagate down that next neuron, whoever that next neuron attaches to and affects. This is complicated, yet this is the basis of how we think, how we remember, act, and behave. Now, this is with normal neurotransmitters. When you throw drugs into the mix, the overall effects are even more unpredictable. If that's not complex enough, we also have other factors to consider. Genetics control differences in every receptor, every different neurotransmitter, every different neurotransmitter production system and capacity for each different neuron and each different part of the brain, every neurotransmitter reuptake recycling system, both at the presynaptic and the postsynaptic side. And if that's still not complex enough, interacts with the genetics to influence the expression of our genes. Genotype is the term used to describe our genetic trait based on what genes we inherited from our parents. Allele is the term used to describe genotypic differences such as hair color, eye color, virtually everything else, including everything listed above. Phenotype is the result of the environmental interaction on our genetic trait. This is very complicated indeed. Nerve impulse transmission with multiple types of neurotransmitters is how thought and memory happen and all brain activity occurs. Drugs mimic neurotransmitters that are already present, generally in much lower concentrations, in the brain. Use of drugs can thus alter behavior, perception, emotions, feelings, thoughts, memory, etc. Our endocrine system uses hormones to communicate and regulate the rest of our body. There is a neuroendocrine link as well. The hypothalamus, neural brain link, produces neurotransmitters affecting the pituitary gland just beneath the hypothalamus. The pituitary is the master gland that regulates hormones all over the body. This affects not only the rest of the body, but the brain as well. The pituitary is the master gland of the endocrine system. It regulates every other gland in our endocrine system. Nerves work through these drugs and neurotransmitters to cause change. If you look at this chart, you'll see that every different drug available has one primary effect. It causes dopamine levels to increase. Secondary effects, some of them will affect alcohol, GABA, and glutamate. Benzos and barbs, the same thing. So you can see that basically alcohol and benzos are alcohol in tablet form. Ecstasy affects serotonin. Marijuana contains endocannabinoids, which has effects in different parts of the brain. Nicotine affects acetylcholine. Opiates react with opiate receptors and the GABA receptors. Note that dopamine is the common denominator for all addictive substances and activities. Dopamine is also known as the feel-good neurotransmitter. Major anatomical structures in addiction. This is a picture of the brain. If you would take the brain and cut it right down the midline, separating the left half and the right half, we would be looking at where the slice was made, looking at the right half of the brain. Down here would be the spinal cord coming up to the medulla oblongata, or oblong body. From there to the pons, which has directive links to the cerebellum. Right here would be the locus coeruleus. These are all different important parts of the brain that will be dealt with in addiction. This area right here is the midbrain. Now, if you stop and take a look at the evolution of the brain, alligators and very primitive beasts will have basically a swelling at the end of the spinal cord, and that's about the entire extent of their brain. Through the course of time and evolution, the brain has evolved in a forward and upward direction. There's a shelf of bone underneath where the pointer is right here. And as it evolved forward, it also kind of swept a little bit backwards, sort of like in a figure S shape. If you look at it this way, you can get a better handle on how the brain evolved over time. From primitive creatures, it stopped about right here. And as you get progressively more complex into the animal tree, so to speak, human beings, will have the cerebral cortex that's very, very enlarged. Smaller, more primitive species, less evolved species will not have this large of a cerebral cortex. The ventral tegmental area is right in here. The hippocampus, right there. The amygdala is the center of emotions. Mesocortical projections. Meso basically means middle, or from the very central portion of the brain. Cortical means up to the cerebral cortex. Hypothalamus is located right here. It's beneath the pituitary gland, the master gland of the body that controls all hormone activity, which would be right about here. Moving further forward and evolutionarily more involved, you get the nucleus accumbens. From there, we get up to the frontal cortex, the prefrontal area, which controls, among other things, impulsivity and judgment. The rest of the body, the rest of the brain, the corpus callosum is a series of lateral projections that connect the right and left hemispheres. The limbic center is part of the emotional center. It's down, projected through the amygdala area as well. The cerebellum is where all of our basic motor coordination and other functions take place, and we'll get into more of that through the rest of this discourse. As we review the neighborhood to kind of understand our terms, let's discuss a few anatomical terms. Superior means to the top or above. Inferior means toward the bottom or below. Anterior to the front, where the face would be. Posterior to the rear, the back of the head. Medial would be middle, toward the midline. Lateral would be off to the side, either right, left, or both. The brain evolved, as I mentioned, from a swelling at the superior top part of the spinal cord into the primitive hindbrain region. With further development, the brain would occur in the anterior superior manner that I described earlier. Folding would become necessary to fit it within the bony confines of the skull. Later in the developmental process, evolutionary, over eons of time, the cerebral cortex, or cortices left and right, would branch out to the sides. The medulla oblongata is the middle oblong, the enlargement at the top of the spinal cord. It controls cardiac, respiratory, vomiting, vasomotor, or blood pressure centers. It's basically concerned with the autonomic nervous system and functions of breathing, heart rate, and blood pressure. Pons, the word means bridge in Latin. Its major functions are sleep, respiration, breathing, swallowing, bladder control, hearing, equilibrium, taste, eye movement, posture, facial expressions, and facial sensation. It connects to the cerebellum for motor coordination and other functions. The locus coeruleus is between the pons and the cerebellum. There are many changes in this part of the brain that happen with those prone to addiction. These changes are passed along genetically. The midbrain is a relatively new part of the brain, developed over the past 250 million years, that's new, after the appearance of the hindbrain, which preceded it. The midbrain includes the emotional and behavioral centers, the limbic system composed of the amygdala and hippocampi. They are on both sides of the brain. The functions of the midbrain: vision, hearing, motor control, sleep, wake, arousal, alertness, and temperature regulation. The diencephalon, or forebrain, it's up toward the top of that S curve that we talked about and below the corpus callosum. This is still considered somewhat primitive brain because the cerebral cortex has not yet been reached. That's the home of the higher intelligent functions. The diencephalon contains the thalamus, which can be thought of as a router or switchboard where a lot of information passes through the thalamus to other parts of the brain. The hypothalamus, which connects to the pituitary, which controls all the endocrine system, hormones all over the body, and the basal ganglia, which are again part of the switchboard apparatus. They're located below and to the front of the forebrain. The basal ganglia and diencephalon in full control voluntary motor movements, procedural learning, things that we do like by hand tying our shoes. Routine behaviors or habits are formed in this part of the brain. Eye movements, cognition or thinking, and emotion. As you can see then, habits happen in a very primitive part of the brain, relatively speaking. So this is why you can teach cats, dogs, even reptiles to do certain little tricks at times. It doesn't require the higher brain functions to get into the habit of doing certain things on certain stimuli. Unfortunately, addiction is thus a very deeply rooted part of our behaviors and brain. The cerebellum at the back of the brain is a finely convoluted, much more than the cerebral cortex. Internally, if you section it, you'll see what's called the arbor vitae, or tree of life. These are all different connections going from different processing areas in the cerebellum and keeping everything moving. The cerebral cortices, the top of the brain, developed about 200 million years ago. This is the newest part of the brain. Obviously, it seems like we're overdue for an upgrade. It's responsible for the higher cognitive functions, language, thinking, all related forms of information processing. Other important aspects of the brain: the cerebrospinal fluid surrounds the outside of the brain, acting as a cushion or shock absorber, providing nourishment to the brain. It also drains through the ends of the spinal nerves into the lymphatic system, which ultimately brings that fluid to the heart, where it's redistributed through the body and to the kidneys for excretion. Inside of the brain, there are hollow cavities called ventricles that are also filled with the cerebrospinal fluid. The spinal fluid is produced in these choroid plexuses that are located within the ventricles. The purpose of these big hollow ventricles filled with the fluid is to help absorb any mechanical forces and protect the brain from any real bad trauma. On the website, I have a PowerPoint presentation and also an outline of the addiction notes. And on those presentation and notes, I've got links to the addiction-related brain regions, function, neurotransmitter input, and projections that summarize the areas of the brain that are involved, what those areas typically do, the neurotransmitters that are active in those areas, what they receive input to, and where they project their output to, which different parts of the brain are involved. There is also a table of neurotransmitters and the drugs that affect them. This is really complex technical information that the average person probably doesn't want to know about, but for those that do, I spent the time to do the research and compile everything, and it helps you to understand and kind of pull it all together for those that are so inclined. So if you would like to look at that, the material has been put together for you. This is a picture of what the addicted brain looks like. You can see down here we have the spinal cord rising up the middle oblong, the medulla oblongata, the pons and the cerebellum, the midbrain, and then the diencephalon. The projections in addiction are very concentrated throughout the primitive central brain. They project out to the cortex in a variety of areas and also have projections that go to the cerebellum. There's a lot of concentration along the amygdala, the limbic system, the hypothalamus, nucleus accumbens, which would all be located in this area right here. The locus coeruleus would be in this part right here as well. This is information that will give you an idea of how complex the disease of addiction is and how much research has gone into it. The neural pathways involved in addiction are very interesting. They're very complicated. They also form in withdrawal. These circuits, prior pathways, can be thought of as circuits ready to be re-energized at a moment's notice. When folks relapse, they don't start with their addictive disease at the level of when they first became addicted. They typically relapse to a degree that was as great as or greater than what they were using when they had stopped using, even if it was decades ago. These neural circuits still exist. Think of a super highway that was built, used for a while, and then for whatever reason falls into disuse. There may be very little traffic going on it, but there's many lanes available to carry a whole lot of traffic in the future should that become necessary. Addiction does change the brain structure and function. It causes impaired decision making, impulsivity, especially in the prefrontal cortex, which has changes in addiction. This compulsivity in the prefrontal cortex causes changes leading to drug-seeking behaviors, cravings, habit formation, relapse triggers, stress dysregulation, and withdrawal, which happens more in the primitive brain areas. The prefrontal cortex can be thought of as a braking system for impulsivity and compulsivity. Addiction involves numerous structural changes in the brain, such as those with the dopamine 2 allele and the locus coeruleus and other areas of the brain, and those with addictive diseases. The mesolimbic system pathways are critical to the neurobiology of addiction. They're located in the brainstem, essential for our basic survival. The ventral tegmental area is located at the front of the mesolimbic center. The VTA projects to the nucleus accumbens, the reward center of the brain. The main mesolimbic neurotransmitter, dopamine, is the feel-good neurotransmitter. Dopamine is released when we engage in activities that help further our survival and the survival of the human species, which of course involves sex. This helps ensure our survival as a species. Things that happen in this part of the brain, this primitive part of the brain, feel that good. They really drive us forward. All addictive drugs and activities release dopamine into the nucleus accumbens. Stimulant-type drugs release more than other classes of drugs. Dopamine is associated with pleasure-seeking and drug-seeking craving activities. GABA and glutamate are also involved. These are other neurotransmitters involved in pleasure-seeking. They're more involved with alcohol and benzodiazepines. Dopamine is also involved in drug craving and dopamine deficiency with withdrawal. Natural cravings like food, water, and sex lessen with time and with satiation. When you've had enough, you've had enough. Dopamine activity increases with habituation. Once satisfied, those are enough. That's a natural craving. With addiction, it's another matter. This is an unnatural desire. Tolerance happens as people need to keep increasing the dose and frequency of their drug of choice to maintain the pleasurable effect and the amount of dopamine which wears off after time and continued exposure to drugs. This amount of dopamine is higher than we can achieve normally without this excessive unnatural stimulation. So instead of having enough and being satiated, we become tolerant and we need more and more, higher doses more frequently. Tolerance drives the drug craving and compulsion to use, driving the addictive process forward. As addiction progresses, these cravings, compulsion, gradually replace the pleasure-seeking impulse of use. This is worsened with drugs such as opiates that have severe withdrawal symptoms in addition to craving. Craving as an attempt to avoid or relieve unpleasant symptoms. So addiction starts with pleasure-seeking and ends up in the trap of using to relieve craving. Eventually, the relief of craving becomes its own form of pleasure. As drug use or addictive activity escalates, the involvement of various brain regions associated with our emotional state also increases. The brain region most often associated with our emotional state is the extended amygdala, part of the limbic system, where our emotional center live or is located. Interestingly, the olfactory bulb is located right next to the amygdala. Scents and smells often have a strong impact on our emotional state for this reason. Scientists think this brain region plays an important role in addiction because of its association with emotions and stress. The amygdala is involved in processing emotions and emotional memory. When the brain forms these memories, it stores the memory of the event along with the emotions that accompanied the memory. The memory of engaging in the addiction is stored with a pleasant emotional state, a positive emotional memory. Thus, the pleasing memories of engaging with an addiction can lead to the repeating these behaviors more and more often as the habit forms. Memory has another role in the development of addiction called cue anticipation. Cue anticipation refers to environmental cues that can initiate or elevate cravings. Cravings then often lead to relapse. This sort of thing could be thought of as an alcoholic who hears the sound of glass ice cubes clinking into a glass and liquor being poured over it will trigger their craving for a drink. For this reason, these cues are often called relapse triggers. These environmental cues or relapse triggers could be anything associated with the addiction. The brain may also form an association between unpleasant emotions and a memory, forming a bad or negative memory. This negative emotional memory of anxiety becomes associated with the physical signs of withdrawal. As withdrawal begins, the symptoms trigger an unpleasant emotional memory. This increases the negative experience of withdrawal, acting as a feed-forward or amplification loop within the neural circuitry. Withdrawal avoidance by returning to the addiction often becomes the cornerstone of addiction in the later stages. Thus, in the early stages of addiction, the pleasurable experience of the drug motivates repetition of that behavior, impulsivity. In the later stages, compulsive relief of withdrawal symptoms becomes a predominant driver. Physical and/or emotional discomfort is avoided as much as possible. This avoidance causes pleasure. This pleasurable relief from withdrawal symptoms continues to motivate the repetition of that behavior. Addiction has been described as dancing with a 800-pound gorilla. It's exciting at first, impulsive, then it's a habit you do, compulsive, and finally you're exhausted, but you're not done dancing until the gorilla is done dancing. Stress and the role of the hypothalamus. The hypothalamus regulates body temperature, hunger, thirst, sleep, and our response to stress. The hypothalamus signals the pituitary gland to release hormones to the endocrine system, which acts on different parts of the body, not just within the brain as neurotransmitters do. Think of the fight or flight of the autonomic sympathetic nervous system. When you have a tiger in front of you, no bars between you, your heart rate increases, your respirations increase, your blood pressure goes up, and you're ready to boogie out of there. These hormones can also act as neuromodulators within the brain, like a neurotransmitter acts. A medical intuitive, somebody gifted with a sixth sense regarding disease and healing, referred to the hypothalamus as the location of our soul. Stress is a major trigger for relapse. Relapse is a bigger problem than withdrawal for addiction patients. Stress and psychostimulants cross-react with each other, promoting relapse. Psychostimulants, amphetamines, cocaine, methamphetamine, are much more difficult to get off of than other addictive drugs due to this cross-reactivity at the neurotransmitter level. Stress, creating an unfortunate cycle. Efforts to stop using cause stress. Stress triggers a release of the stress hormones from the hypothalamus. Dopamine and serotonin activity in the nucleus accumbens actually decrease with this stress early in recovery. These calming neurotransmitters normally would help reduce the stress. This is a disruption of the normal stress response that occurs with addiction and withdrawal. The dopamine and serotonin neurotransmitters should be increasing to help cope with the stress, but in reality, they decrease, especially with the psychostimulant abuse. Stress triggers addictive behavior, use. Thus, withdrawal causes stress, which can trigger more addictive use, which causes stress to the addict who is unable to stop using the drugs, and a vicious cycle in which the normal calming or breaking serotonin and dopamine activity from the nucleus accumbens is lost. Recovery is the process of breaking this cycle. It takes a lot of motivation. Medications can help, but recovery still requires effort. The brain is very adaptable. It learns. That's what it was designed to do, to learn. Recovery is a process of learning. Learning involves forming new circuits and pathways in the brain. Many recovering addicts testify that the first step effort at recovery is much easier than recovery after numerous slips or relapses. The first is a gift. It's progressively harder to recover after the first attempt. This is one of the spiritual axioms of recovery. Related brain areas and the neurotransmitters and their functions. The negative emotional memory in the amygdala is associated with drug withdrawal. The positive emotional memory in the amygdala is associated with drug cues. Hypothalamic and nucleus accumbens, serotonin, calming, and dopamine feel-good disruption occur to stress or dysregulation. The pleasurable relief from withdrawal symptoms occurs by resuming drug use or addictive activities, reduce stress, and soothe the hypothalamus. Opiates inhibit the firing of neurons in the locus coeruleus. When opiate consumption is stopped, the increased activity of the locus coeruleus contributes to the symptoms of opiate withdrawal. An alpha-2 adrenoceptor agonist called clonidine is used to counteract this withdrawal effect by decreasing adrenergic neurotransmission from the locus coeruleus. Remember, alcoholics and addicts have altered dopamine 2 alleles in the locus coeruleus part of the brain. Why are drugs addictive? The brain makes its own drugs. If you look at this table, there are 3 columns. The left column would be the normal neurotransmitters in the brain. The middle column would be the drugs that mimic those neurotransmitters. And the far right column would be the receptors located in the brain, where they're located. So on the left, you see that endorphins and enkephalins are produced by the brain. They're mimicked by morphine, heroin, the opiates. Receptors are all over the brain. Anandamide is a neurotransmitter that's mimicked by the cannabis, THC, marijuana family. Most of those receptors are in the superior brainstem. Acetylcholine involves the nicotine receptors throughout the entire brain. Dopamine, mimicked by cocaine, amphetamine, methamphetamine. Receptors are mainly in the mesocortical and mesolimbic area. Gamma hydroxybutyrate, GHB, the drug that mimics that would be alcohol and the benzodiazepines, alcohol in tablet form, found throughout the modern and primitive brain areas. Serotonin and glutamate are mimicked by hallucinogens. They're located mainly in the parahippocampus and the cerebral cortex. Drugs hijack the reward system of the brain. Drugs of abuse mimic the brain's own neurotransmitters. They stimulate the brain's receptors in the reward system, causing dopamine release, leading to the artificial high. Occasional use starts the impulsive cycle. It feels good. Let's do it again, teaching the brain to anticipate reward. This leads to the compulsive cycle. Repeated exposure leads to craving, to brain adaptation, neuroplasticity, and repeated use. Neuroplasticity is the physiologic anatomic term of more receptors forming because there's so much drug there, the brain makes more receptors for that excess amount of drug. Neurobehavior change is the behavioral mental health term for what goes on with neuroplasticity. And again, this is basically an increased number of receptors forming for any given drug or neurotransmitter in any specific area of the brain when there's more drug than can occupy the receptors. Those receptors are located all over the brain. There are several different main receptor types. Delta is involved in pain relief. It's an antidepressant, can cause seizures, physical dependence, and decreases breathing. Kappa is involved in pain relief, has anti-seizure effect, can cause depression, disassociation, hallucination, urine flow, dysphoria, making you feel bad, small pupils, has neuroprotective effects, causes sedation, and can cause stress in excess amounts. The mu1 is involved in pain relief and physical dependence. Mu2, respiratory depression, narrowed pupils, feeling good, constipation, physical dependence. The nociception receptor causes anxiety, appetite, depression, development of tolerance to the mu effects. Zeta is involved in embryonic development and regulation of cancer cell proliferation. The cannabinoid system. And the neocortex, the higher cognitive functions of thought, integration of sensory and information. In the cerebellum, it's involved with motor control and coordination. This is where the largest number of endocannabinoid receptors are located in the brain. There are also receptors in the hypothalamus, where it's involved with regulation of appetite, sleep cycle, sexual behavior, reaction to stress, and hormonal levels, the neuroendocrine link. The basal ganglia THC receptors are involved in motor control and coordination. In the ventral striatum, they project into the feelings of reward in the hippocampus and the amygdala. The hippocampus, memory, learning of facts, sequences, and places. The amygdala, anxiety, emotion, fear, paranoia. Excuse me, brainstem and spinal cord, the vomiting reflex and sensation of pain. Acetylcholine has two major types of receptors, nicotinic for nicotine and muscarinic. These receptors are located throughout the brain: the thalamus, deep layers of the cerebral cortex, ventral tegmental area, medial habenula, substantia nigra, and pars compacta. There's an A3 receptor strongly expressed in the locus coeruleus, habenula, and intrapedicular nucleus. Peripheral tissues also have strong concentrations of the A3 receptor in the autonomic and sensory ganglia, and the A4 receptor is quite prevalent in the trigeminal ganglion, which involves the face. Dopamine and norepinephrine system. The mesolimbic system involved with ADD, ADHD, addiction, schizophrenia. The mesocortical system, ADD, ADHD, addiction, schizophrenia. Nigrostriatal area, addiction, chorea, a dancing-like movement, and Parkinson's, another movement disorder disease. And finally, the tuberoinfundibular area of the brain, which is involved in hyperprolactinemia, which often causes nipple discharge. Gamma hydroxybutyrate, the GABA system, has a neuroinhibitory functions. The main areas would be the frontal cortex, memory, emotions, thoughts, cerebral cortex, thought coordination, cerebellum coordination, nucleus accumbens, the reward addiction centers working with dopamine and serotonin, the amygdala involved with emotions, survival instinct, and memory, and the hippocampus. Medication-assisted treatment, MAT. Medications can make addiction treatment easier and more successful for the patient. Medically assisted treatment involves the use of medications to not only help with the detox phase of treatment, but also to help patients have an easier time getting into recovery. Medications and protocols are available for use for abuse and addiction of all the major drug classes: alcohol, amphetamines, benzodiazepines and barbiturates, cocaine, ecstasy, inhalants or huffing, marijuana, methamphetamine, nicotine, and opiates. The best success rate for medication-assisted therapy is with opiates. There is no such thing as a medication to cure addiction. Cure means a one-time treatment producing permanent results, such as with a strep throat. Control means that if the treatment is used, the problem can be controlled. Diabetes, high blood pressure, and others can be controlled but not cured. Treatment to control generally requires periodic monitoring and possible adjustments of dosage, medication, and other factors. Various medications are used to treat addiction to specific substances. There is no one-size-fits-all. Treatment is tailored to an individual patient's need. Dual diagnosis or comorbid conditions also need attention for successful treatment. Most folks use drugs to feel better. Sometimes people are self-treating various forms of mental illness that may have never been diagnosed, much less properly treated. Numerous mental health issues must be addressed for proper addiction treatment. Anxiety, depression, bipolar disorder, also known as manic depression, post-traumatic stress disorder, psychological trauma, traumatic disease can be helped with addiction medications. Many of these can be successfully managed. Sometimes other help is needed. Psychology, psychiatry, clergy, family therapy. Although addiction can mimic every form of mental and emotional disease, treating the chemical imbalances caused by these conditions is crucial to attaining meaningful recovery for the patient. Ignoring these comorbid dual diagnosis conditions does a great disservice to the patient. Acupuncture or AccuDetox can be quite helpful and has been shown to double the success rate in long-term recovery from drug abuse. Acupuncture is a form of Chinese medicine that is over 5,000 years old. It's still being used because it works. The theory behind acupuncture is that there is a flow of qi, the vital life force, in everybody. This energy of life flows through specific channels called meridians. Treatment can be done with beads, seeds, and needles. Needles with electrical charges applied and needles in which specific Chinese herbs are burned, a process called moxibustion. There are 5 acupuncture points in the outer ear that are treated. The Shenmen, or heavenly gate, calms the spirit, decreases anxiety, insomnia, and pain. The sympathetic calms the fight-flight response and causes sympathetic nervous system balancing. The kidney is thought to deal with emotion and fear. The liver point detoxifies and unblocks stuck energy, both emotional and physical, while addressing the emotion of anger. And the lung helps us to let go, especially of grief or sadness. Buprenorphine effects. Consider 6 different colored padlocks: delta, kappa, mu1, mu2, nociception, and zeta. Each lock has a different function. Agonist agents fit into the lock, turn, open, and activate the lock or receptor. An antagonist fits into the lock but won't turn, open, or activate the lock or receptor, preventing any other molecule from engaging the receptor, blocking its effect. Buprenorphine is a mixed agonist-antagonist. It's a partial agonist-antagonist at the mu1 that does result in pain relief. It's an antagonist of kappa. It has mixed effects on other receptor subtypes. Norbuprenorphine is a metabolite of buprenorphine that does have psychotropic properties. It blocks the mu2 receptor. There's no euphoria, no high. It actually blocks people from getting high. 8 milligrams of sublingual buprenorphine will give an 86% receptor blockade in opiate-tolerant dependent users. 16 milligrams under the tongue will cause a 94% blockade. 24 milligrams will cause a 97% blockade. This is the Suboxone or Subutex brand that comes in 8 milligram doses, 1, 2, or 3 tablets. The brain can tell the difference between 8 and 16 milligrams, 86% to 94%, or an 8% difference in receptor blockade. The brain cannot tell the difference between 16 milligrams and 24 milligrams, otherwise a 94 to 97% or only 3% blockade difference. However, 24 milligrams can be used short-term for acute pain syndromes if needed, such as after surgery. Remember, Buprenorphine blocks the euphoric effect of opiates. They sure don't make heroin like they used to. Buprenorphine relieves and prevents craving, stops pain. It's actually used in open heart surgery for pain control. The receptor half-life is 30 hours. Plasma half-life is 3 to 5 hours, but it has a very high affinity for the receptor, which causes a much longer half-life. After the 16 milligram dose in 30 hours, 8 milligrams is still working. 30 more hours, 4 milligrams is still working. This is what a half-life means. This strong affinity for the mu2 receptor means that the bup receptor bond at the mu2 receptor is about 500 times stronger than the receptor's affinity for morphine. This means that a much longer time is necessary before the buprenorphine will randomly bounce off the receptor than morphine or heroin would. It should be noted that molecules and atoms sort of bounce around and have energy. They will eventually leave the receptor. The stronger the affinity the receptor and molecule bond is, the longer that receptor will be occupied by a given agent. This explains why having used bup will ruin attempts to get high by using heroin for more than a day after the last full therapeutic dose of buprenorphine has been taken. Transitioning from methadone to buprenorphine deserves special mention and review. Many methadone clinics put their patients on high doses of methadone, whether they need it or not, to control their addiction and/or pain. The best way to convert a patient from methadone to buprenorphine is to start when the patient is down to about 30 milligrams of methadone a day. The patient may need to be slowly titrated down to this level. It may take many weeks to do so. Methadone has a very prolonged and variable half-life of 8 to 60 hours. It's metabolized in the liver by the cytochrome P450 CYP-3A4 subreceptor types. It's metabolized by the same liver enzymes as methadone and buprenorphine. Converting the patients from daily methadone doses above 30 milligrams is possible, but the patient will be uncomfortable. This is unavoidable. Due to the long half-life of methadone in the body, it must be stopped for 2 days before bup can be initiated. Even then, there will probably be some opiate withdrawal symptoms. Medications are prescribed to ease the various withdrawal symptoms that will be expected. Buprenorphine treatment should be started when the patient is in early or mild opiate withdrawal. Starting this medication while the patient has high level of other opiates, pain pills, heroin, methadone, can trigger opiate withdrawal or cold turkey type symptoms. Buprenorphine is not absorbed in the gut. It works well transmucosally across moist surfaces such as the inside of the mouth. It is best dissolved in the mouth, held in the mouth, with the saliva being not swallowed but swished around in the mouth, using the tongue to sort of paint the surfaces of the mouth, the cheek, tongue, under the tongue, gums, etc. Try to keep the drug-containing saliva in the mouth for at least 15 minutes. Do not smoke cigarettes or anything else before taking the medication and for as long as possible after the medication. Avoid brushing teeth before medicating and for as long as possible after medicating. Some toothpastes contain astringents, which can lessen the absorption of the drug. To give an idea of the different forms, Subutex is pure buprenorphine. It's available generic right now. Our retail cost would be about $4.50 a tablet. On the street, that would go for $25 to $40. Suboxone is the same medication, but with the addition of naloxone, which is an opiate blocker, which means it cannot be snorted or injected. This is the preferred medication type. It tastes a little bit better. In most clinics use this instead of the pure Subutex or buprenorphine. Cost is about $7.73, $20 to $25 on the street. Suboxone also comes in a film preparation. There's Zubsolv, which has a slightly different dose. It's absorbed a little bit better, and that's why it has the lower dose. It's a bit more expensive. Then Bunavail is also usually a little bit more expensive, not quite as much as the Zubsolv, and has a much lower abuse potential. As far as Medicaid is concerned, Suboxone film is their preferred agent at this time. Buprenorphine effects. Naloxone is a drug that's used to counter the agents, the opiate agents. It blocks all opiate activity. This is especially useful in overdose when breathing stops. It can restore breathing, blood pressure, etc. The Evzio auto-injector is available at about $3,742 per dose. Narcan in a vial would be available for about $65 a dose. The Evzio injector, however, is available on a compassionate use protocol. Most insurances will pick up the tab, and there are a variety of different types of programs by the company that makes this medication to make it available at a much lower dose. Neuroplasticity. Drugs work on specific receptors. The neurons that fire together wire together and form stronger linkages. There are many different types of neurotransmitters which have different types of effects. Glutamate is generally excitatory. Glutamine is generally inhibitory. Gamma-aminobutyric acid, or GABA, tends to calm and inhibit. Serotonin also has a calming and inhibiting effect. Norepinephrine is excitatory. Dopamine is known as the feel-good neurotransmitter. Prolactin is the in-love transmitter. It's what's released when people fall in love. Endorphins are also mimicked by morphine and other opiates. They are naturally present in the body to relieve pain and other brain functions. There are many other neurotransmitters that exist. We still don't know all of them, but research continues. When there is an excess amount of activity of a neurotransmitter or drug, as in the addiction or a routine heavy user, the brain can respond by increasing the number of chemical receptors, e.g. on the next neurons, so that the excess amount of drug or neurotransmitter will have receptors to occupy while leaving some receptors empty to restore the normal tone of the brain and the neurons in the presence of that excessive amount of the drug or neurotransmitter. This is a natural compensatory homeostatic mechanism. This causes tolerance, the situation where the same dose of the drug has less of an effect, such that more drug is needed to maintain the desired effect. The opposite condition also occurs. If one has been a heavy user and suddenly stops, symptoms of drug withdrawal can happen. At the cell membrane, what is happening is that there are now many empty unoccupied receptors on the next neuron. This alters the normal function of that neuron. Under conditions in which it would normally fire or trigger an electrical impulse, it may remain silent, or under conditions in which it would normally be quiet, it may start sending false signals. The withdrawal symptoms are specific to each of the various drug types used. Detoxification. Withdrawal is never a pleasant process. It can kill as well. A brief review is in order. Alcohol withdrawal can be lethal. It needs to be done under medical supervision. Amphetamine withdrawal symptoms, people are typically sleepy, tired, irritable. Barbiturate withdrawal also could be lethal. Needs to be done under medical supervision, as does benzodiazepine withdrawal. Cocaine withdrawal typically causes irritability and fatigue. Marijuana does not have a significant withdrawal syndrome. The drug is stored in fat. We talked earlier about distribution. Distribution means where the drug goes in the body, and marijuana is very likely to end up in fat cells, where it stays for a long period of time and will leach out slowly over time, forming a sort of an auto detox. Opiate withdrawal, dancing with the cold turkey, the shakes, the sweats, nausea, vomiting, diarrhea, tremors, yawning, runny nose. You may feel like you'll have to get better to die. You wish you would die, but it's actually very safe and you won't die from opiate withdrawal. You'll just wish you could. Neuroplasticity is the term that describes both situations above. Too many or too few receptors for any given condition. This is how the brain adapts to try to maintain homeostasis, a desirable steady state or normalcy of sorts. Psychological aspects of addiction. It's important to understand the difference between psychiatry and psychology. Psychiatrists are physicians, medical doctors, or doctors of osteopathy. They prescribe medications to correct abnormal brain chemistry as reviewed above. They tend to place an emphasis on neurochemical modifications of one's emotional and mental problems and state. They do, however, engage in some forms of talk therapy. Psychologists, on the other hand, generally have a doctorate, a PhD, in what can be considered talk therapy, which involves discussion with the patient, diagnosis forming, and a variety of different types of talk therapy to help the patient come to an understanding of different perspectives, ideas, beliefs, and ultimately feelings and behaviors. Psychological theories on why addiction happens. Addicts may engage in harmful behaviors because of concurrent mental illness. They may learn unhealthy behavior in response to their environment. Thoughts and beliefs create feelings, which in turn determine behavior. If thoughts, beliefs, and feelings are unrealistic or dysfunctional, behavior may be affected. Psychologists assume these theories apply in some way to addiction. People with these disorders might include cognitive difficulties, mood disturbances, and other mental illnesses. Addiction and other mental health disorders commonly occur together, a concept known as comorbidity. Half of the people seeking addiction treatment will have another significant mental health disorder. Many who suffer from addiction have attempted to self-treat their mental illness with available psychoactive substances, drugs, to ease their suffering. It's impossible to get somebody with comorbid conditions into good, stable, long-term, successful recovery if these other issues are ignored. That's why in our practice, we try to uncover as much as we can about what else may be going with the patient's mental, emotional, and behavioral state so that we can come up with a diagnosis of other forms of comorbid illness that need to be treated and then treat them appropriately with the right medications, not necessarily street drugs. Examples of emotional and mental disorders commonly comorbid with addiction include attention deficit and hyperactivity disorder, anxiety, bipolar disorder, depression, post-traumatic stress disorder, and various forms of trauma, including psychological trauma. The addictive personality, a set of personality traits that predispose an individual to developing addictions. This hypothesis states that there are common elements among people with varying addictions that relate to personality traits. There are several distinct personality disorders listed in the Diagnosis and Statistical Manual, Edition 5, which is the basic handbook of psychiatry and psychology that codifies all emotional and mental health disorders. Review of this document, however, reveals an absence of addictive personality disorder. There are, however, basic, informal, non-coded personality traits associated with addiction, including denial of obvious problems, problems with emotional regulation, and problems with impulse control and regulation. Psychotherapy attempts to identify and resolve underlying psychological disorders. Self-realizations and help from a qualified therapist can help uncover some of these issues. The therapeutic relationship of the patient with the therapist is critical to ensuring enough trust is present that difficult issues can be explored. Absolute honesty and diligence is required for success in any such form of therapy. Locus of control. Recognition and acceptance of personal responsibility for problems and their solutions bring to the surface deeper underlying issues. Do we see ourselves as internally directed, responsible for our own actions, or externally directed? Things just happen because they happen. We don't have much responsibility for the major events of our lives. Fate or karma seems to be the main driving force. There is a brief online test that can help determine which locus of control you believe in. This link is available in the PowerPoint presentation and the outline on the website. Nobody is entirely internally or externally directed. Generally, though, we will have a predominant belief in one versus the other as having control in our lives. Theories regarding responsibility for addiction. The medical model, people are not responsible for creating or solving their own problems. The compensatory model, people are not responsible for creating but are responsible for solving their own problems. The moral model, people are responsible for creating and solving their own problems. The enlightenment model, people are responsible for creating but not solving their own problems. What's the best way to make sense of all of this? Since we've established the genetic, biologic, medical basis of addiction and the fact that none of us can choose our parents or genetic makeup, it seems that the compensatory model fits. People are responsible for solving but not creating their own problems, thus the compensatory model. Yet, Who among us hasn't behaved in a manner that worsened our addiction, made poor choices, leaving us to consider other options? We've established the biological nature of this illness, which makes the moral model less likely. Wouldn't it be great if we were not solely responsible for fixing the mess that we made of our lives? This line of thought leads us to an answer. Spiritual and moral aspects of addiction. Addiction is a disease with much more than fascinating anatomy and physiology, pharmacology, and behavioral aspects. It's also very much a spiritual disease. Like any other disease, it's essential to evaluate and treat every aspect of the disease before it can be subdued and controlled. Moral aspects of addiction. There's a difference between religion and spirituality. Religion is the belief in and worship of superhuman controlling power, especially a personal god or gods. Ideas about the relationship between science and religion, a particular system of faith and worship, or a pursuit or interest to which someone ascribes supreme importance. Spirituality, on the other hand, is a much broader concept with room for many perspectives. Extracorporeal simply means without a body, non-physical. In general, it includes a sense of connection to something bigger than ourselves. It typically involves a search for meaning in life. As such, it's a universal human experience, something that touches us all. This is transcendence, an existence or experience beyond the normal or physical level. Moral, this concept of spirituality is different and much more simple than religion. Agnosticism or atheism does not need to be an obstacle to recovery from addiction. All of the 12-step programs use the concept of a higher power. Some people choose God, some don't, and still get sober. This higher power is whatever an individual addict chooses it to be for himself or herself. It does not need to be God. The USSR adopted the AA program referring to GOD as group of drugs or drunks or addicts, despite their strongly professed atheistic state policy. Stanley Miller did an experiment demonstrating the possibility of creating organic compounds by applying energy to a primordial stew of simple chemicals. Carl Sagan once wrote that the odds against a specific human genome being assembled by chance is 1 times 10 to the 2 millionth power. It seems very unlikely that humanity came into existence solely by chance. The purpose of evil spirits. Addiction is a progressive disease. It is a disease of yets. Name your poor outcome or bottom. It simply has not happened yet. Even with periods of abstinence followed by later relapse, the depth of the relapse will be much worse than the status at the earlier stage of addiction. Abstinence means not indulging in a substance or behavior. This is not the same as recovery. Recovery is essentially the restoration of mental, emotional, spiritual, and physical health. Addicts use to feel better. Imagine being able to feel better without the need to use. Addicts at some level will realize they are different from, quote, normal, unquote, people, the normies. This difference is actually a gift. The gift of addiction means that we need to work harder for the spiritual connection and other normies seem to require. Sadly, in this culture, very few people recognize the need for that connection. Addicts do not have that luxury. When we actively pursue that connection with our higher power, whatever we conceive the higher power to be, we get incredible blessings or gifts for the extra effort required. Choosing to not pursue this connection is our death sentence, a death that is eternal to our soul. Addiction and recovery. Recovery is a process. It takes time. It's a process of growth. Our spiritual self is always moving, either to greater recovery or backsliding toward a relapse in addiction. There is no such thing as standing still. We must continually work the program. The rewards of this program. Addiction causes distorted perceptions, not only when somebody is high, stoned, or abusing the drug, but even before the drug has ever been tried. Addicts and alcoholics see things differently and react differently. The first use of the substance seems to let the genie out of the bottle, accelerating the course of this disease of addiction. Addicts use these distorted perceptions to make decisions. These decisions are not always good and often lead to less than desirable results. Emotional growth is thought to stop at the age at which use starts as far as illicit drugs are concerned. This is even more pronounced with drugs such as THC and marijuana that affect the prefrontal cortex in the brain where judgment and impulsivity reside. In short, addicts end up with changes in the brain that are best described as a form of brain damage. A quick story here is in order. I'm going to talk about Adam and Chris. Adam came in as an opiate addict. He wanted help. Ended up on Suboxone. He seemed to do okay. I took care of him for about a year, and he said, "Would you be willing to see my brother Chris?" "Sure, what's his problem?" "Well, he uses cocaine." "Yeah, by all means, send him in. I'll be happy to see him." When Chris came in, he looked terrible. He looked very, very sick. He was just in really bad shape. Chris was otherwise a good-looking guy, about 5'5", blonde hair, tanned, muscular, well-developed. He had his master's degree in oceanography, specifically oceanographic topography. He was wanted up and down the east coast of North America. He used to specialize in mapping the seafloor in preparation for beach restoration projects. He had his master's degree. He worked very hard. He was making a good income, but then he started using drugs on the job. A further history revealed that he worked a lot on offshore heavy equipment barges where there was a lot of welding and other metal work, as well as a very risky environment to work in. He had seen a couple of people cut in half when steel cables had broken and whipped back and hit them. He had been exposed to metal fumes. Suspicious, I did a chelation therapy on him and I collected his urine, which revealed that he had a huge burden of toxic heavy metals in his system. We started chelation therapy to get rid of these heavy metals, and as we did so, he gradually improved. I'd also put him on medication to help with his addiction, medication-assisted therapy, which we specialize here at Blue Ridge Family Medicine. As he slowly got better from the poisoning from the metal, he went from sleeping 22 hours a day to 20 hours a day to 18 hours a day and so on. His sleep requirements gradually diminished as the metals cleared from his body. He took very well to recovery. He never relapsed. He got right off of the cocaine. Probably he was using all the addictive drugs therapeutically so he could try to stay awake and alert in a dangerous working environment. He did have addictive tendencies, but I think his main problem was the metals. So as Chris continued to get better, he got to the point where he was able to get a job, and he worked as a dive master on a recreational dive boat. So every once in a while, we'd come in from his visit. He'd bring a cooler full of frozen lobster tails as a thank you gift. A very well-remembered patient for many reasons, not the least of which was the lobster. Meanwhile, his brother Adam, who had been quite obese, took a trip to India where he had gastric bypass surgery done. It was cheaper than having it done in the United States as he had no insurance. He came back. I took the staples out. He seemed to be doing well. Chris said that he was really not in recovery, but every time I did a urine test, he had the expected results. Finally, one Friday evening, I got a phone call from his mother, and as it turned out, Adam had gotten himself into some trouble, and there had been a terrible, terrible misunderstanding. Adam, it turned out, had gone to jail. He had been to jail because he had robbed a bank. What had happened is he had been using his opiates. ran out of money because he wasn't getting enough of the Suboxone that he was selling to get as much heroin as he wanted. Remember, this is a progressive disease. He robbed a bank. On the way home, he burglarized several homes in the neighborhood where police officers lived. And he ended up going to jail for bank robbery and burglary. He still had the jacket he wore to the bank on in the front seat of his car when the police came by to arrest him. The SWAT team took him away. His mother explained it was all just a terrible misunderstanding, full denial with her codependence and the depth that his addiction disease had brought him to. This is how addiction distorts perception. There's a phrase that I love. I did not get in trouble every time I used, but every time I got in trouble, I had been using. And this truly is illustrative of what Adam went through. Chris, on the other hand, got the metals out of his system and ended up going back to work in his chosen profession and never had problems with drugs again. Having been bitten once, he never returned. Two heads are better than one. Collective brain power. Two heads can be a good defense, but where do you get these two heads? Well, the 12-step meetings. You look for the group members with a better long-term sobriety. Get to the meeting well before the meeting starts for the informal meeting before the meeting, which may be in the parking lot. Stay afterwards for the meeting after the meeting. The folks who go to these meetings now are the same folks who used to be the life of the party. They insist on having a good time. They love to laugh and kid around. They know that they cannot keep their own gift of recovery without giving it away to newcomers whenever the opportunity arises. Newcomers are helping them by showing up at meetings. They will insist that the above is true. They really mean it. Even if you're not welcome anywhere else, they will welcome you warmly. Tolerance is defined by either of the following: need for markedly increased amounts of the substance to achieve intoxication or the desired effect, or a markedly diminished effect with continued use of the same amount of the substance. Withdrawal is manifested by either the characteristic withdrawal syndrome for a given substance, or the same or closely related substance is taken to relieve or avoid withdrawal symptoms. The substance often is taken in larger amounts over a longer period of time than intended, largely due to tolerance. There is also a persistent desire or unsuccessful efforts to cut down or control substance abuse. The diagnostic criteria. A great deal of time is spent in activities necessary to obtain the substance, such as visiting multiple doctors or driving long distances. Use of the substance frequently, such as with chain smoking, or time taken to recover from the effects of the substance. Important social, occupational, or recreational activities are given up with or reduced because of use of the substance. The substance use is continued despite knowledge of having a persistent physical or psychological problem that is likely to have been caused or exacerbated by that substance. For example, current cocaine use, despite recognition of cocaine-induced depression or an ulcer in the nose being made worse by the illicit consumption. Legal problems related to abuse. I'm sure there's more than one of us here who's had a DUI or other issues, even spousal abuse or marital conflict, all sorts of different problems. Medical problems related to abuse. Addiction has genetic underpinnings, strong effects on the family. If one parent is susceptible to addiction, whether they choose to use or not, there's a 50% chance that the offspring will have that gene. Actually, it's not a single gene, there are numerous genes that carry the addiction genes, characteristics. If both parents carry the gene, the chances of passing it on are closer to 100%. The genetics of addiction probably involve numerous genes that are thus complex and not yet fully understood. A review of family history will often reveal members of the family tree who were alcoholic, addicted, suffered from emotional and mental disorders, or died early. Suicide is often associated with addiction. Recall that mental health is a very new field of study. Even a generation ago, somebody may have been considered not right in the head, or avoided, if not outright shunned, and not talked about in family. Obviously, the addict's behavior has wide-ranging effects on not only the immediate nuclear family, but often on the more extended family of aunts, uncles, cousins as well. Many families with the presence of addiction attribute addictive behaviors to normal. It's the only behavior we've ever known. Families and people are thought to only be as sick as their secrets, and we learn at a tender young age that there are certain things we just don't talk about outside the family. Codependence can be considered another aspect of addiction. Family members enable the addict. Once an addict is addicted to the other addict, they are enmeshed in their codependence, calling in sick for them when they're unable to attend to their responsibilities due to effects of the substance behavior or withdrawal, tolerating and hiding unacceptable behavior. Accepting unacceptable behavior makes that behavior acceptable. Divorce and failed relationships are often due directly or indirectly to addictive behaviors. This may be frustration in dealing with the ism of alcoholism or drugism. Ism basically means I, self, me. I'm not much, but I'm all I think about. Such behavior has its limits and is rarely tolerated forever. The single most important predictor of successful long-term recovery is the motivation of the patient. The addict must put the recovery ahead of everything else in their lives. If they start to falter, slow, or stop aggressively working the program of recovery and putting it ahead of everything else in their lives, they will lose it. If they think their job and income is more important, that job and money will be lost with their next relapse. If they think a relationship with spouse, children, parents, siblings, friends is more important, those important people in your life will leave with the relapse. Early recovery demands all of your attention. The patient in the intensive care unit needs to concentrate on getting better. Early recovery is a lot like being in the ICU. When an ICU patient improves, they are eventually transferred to a lower level of care in the hospital until they are able to leave the hospital. Recovery is just like that. Early, for at least the first year or until the 12 steps are worked under the guidance of a good sponsor, the addict should consider themselves to be. In the ICU of recovery, you should be going to frequent 12-step meetings. At least 90 meetings in 90 days is recommended as a bare minimum when you start working the program. Paying attention at those meetings, looking for the person who every time they share, the recovering person feels like he or she wants what that addict badly needs and wants. Frequent contact with other recovering people, doing what is recommended by others in the meetings, choosing a sponsor, at least a temporary sponsor initially, following your sponsor's advice completely and religiously, knowing full well that your sponsor is saving your life. Being totally honest, which will improve over time. The truth comes out like total honesty. You can't handle the truth, Jack Nicholson was famously known to have said. Early in recovery, the truth would overwhelm you. The truth comes out over time. This is a gift. Time takes time. Later in recovery, you will learn to balance and include family, friends, career, money, and integrate everything all around your recovery program and your spiritual development. This cannot be stressed enough. There's a lot to be said about having the addict take responsibility, financial and otherwise, for their own recovery. Perhaps giving it to the family member or employee as a gift the first time can be considered as far as going into a treatment center. After that, however, responsibility includes paying your way. Those who are constantly being given a free everything have no skin in the game. Recovery is therefore worthless to the mind of the addict. It didn't cost him anything. The second most important point to make then is that no matter how much you care for or love your addict, tough love may be the only thing that works. The addict must want to get better for themselves. They cannot and will not get better for somebody else, no matter what they say. Addiction is a disease of dishonesty and of self-will run riot. Terminal selfishness. Recovery is a lot like sex. If you're not having a great time, you're doing something wrong. Mental. It'll take time for the distortions in the fog to clear. Comorbid dual diagnosis conditions need to be diagnosed and treated properly in the early phases of treatment. The diagnosis and need for treatment with medications may change through the course of recovery. Addiction mimics every mental illness. A prudent therapist won't give anybody a firm mental health diagnosis until at least of recovery, not merely abstinence, has passed. Insanity, repeating the same behavior expecting a different outcome. Albert Einstein came up with that one. The more time in recovery that passes while working the full program of recovery, the more socially, morally balanced and integrated we become. We will not regret our past nor wish to shut the door on it. Emotional. Feelings are not facts, and facts are not feelings. Addiction distorts and masks our emotions and feelings. Addicts frequently don't know what they're feeling. Many addicts don't fully understand what they're feeling at any given moment. Users typically done to take the pain away. This also numbs the normal, natural feelings that we have. Feelings are neither good nor bad, they just are. Emotional growth appears to stop at the time of the initial use of the addictive substances. Think of a 30-year-old person with the emotional depth of a 15-year-old. Spiritual. Those who choose to cultivate a religious belief typically progress farther and faster in their recovery. It's been asked of me, how quickly do I have to do those 12 steps on that window shade in the meeting room? The answer is, how soon do you want to feel better? Even the agnostic should consider this fact and reconsider their belief or lack of belief and become open-minded to changing their opinions on the definition of a higher power. Remember that addiction is a me disease with a we solution. It's a simple but not easy program. It is only for those who want it, not for those who need it. Because of this, we cannot accomplish recovery alone. It requires a group dynamic. This is a simple program for addiction ravages the body. The exact organs damaged often depend on the substances and behaviors indulged in. Intravenous drug abusers increase the risk of HIV and hepatitis, liver inflammation, often viral, as well as heart infections. Alcohol damages virtually every organ and system in the body. Tobacco damages the lining of airways, lungs, and blood vessels. Complete cessation of abuse is absolutely crucial and mandatory for physical recovery. It's not uncommon for miraculous physical recovery to occur among those who work the full recovery program. Many treatment centers will ban smoking to stop all addictions in one treatment. This isn't done by all of them, is somewhat controversial, but is not a bad idea. The 12-step program is the backbone of all recovery programs. True recovery integrates, coordinates, and improves all of the domains. Medications can be used to assist, but they only assist in the recovery process. Medications treat the biologic, medical aspect of the bio, psycho, social, spiritual aspect of addiction. When dealing with addiction, which is truly a lethal, terminal, progressive disease, it's best to use every tool available, all simultaneously. Jails, institutions, and death are the ultimate and usually premature outcome of this cunning, baffling, powerful, ruthless, and lethal disease. Addiction truly is a terminal illness. Reasons for addiction continuation change over time, remember. Early, it feels good. Its use is impulsive. Later, it's a habit. It's compulsive. Finally, it's like dancing with that 800-pound gorilla. I hate it, and I can't stop because it hurts too much to try to stop. Pain is a very good thing, however. When what you're doing hurts more than the pain of the thought of changing, you will change. And until you really come to that conclusion and fully, truly decide for yourself that you want to change, change will not happen. That's why I repeat, the most important aspect for recovery to be successful is the motivation of the person seeking recovery. It's important to understand in this disease model that use, abuse of the drug or behavior is also only a symptom of the underlying problem. We use to feel better. That means there's something wrong with us. We don't feel good normally. Recovery gets us to feeling good normally. The behavior is just a coping mechanism to deal with this underlying feeling of dis-ease. Recovery entails fixing the problem at its root cause. Recovery entails working the program of recovery. Recovery is a verb. Addiction recovery has a few vitally important concepts. It is a me disease with a we solution. It is impossible to get sober alone, with your distorted perceptions leading to faulty choices. It's a simple but not easy solution and program. It's a simple program for complicated people. And there's nothing wrong with asking for help on a huge and difficult task. Would you be sitting here reading this if you had not gotten clean and sober by yourself? So that repeating the same behavior, expecting a different outcome, expecting to get sober, straight, clean by yourself, that's another definition of example of your insanity. It works if you work it. So work it because you're worth it. Sponsorship. By going to meetings regularly, in part looking for that person who, every time they share, you respect what they have and you want what they have in terms of emotional sobriety, mental and emotional health, wisdom, the peace that they have just attracts you to them. Ask that person to sponsor you. It's truly a great compliment to that person. You're telling that person how much you admire them and want to be like them when you ask them to sponsor you. You work the 12 steps only as guided by your sponsor. You do not do this alone. The sponsor's job is to guide the sponsee through the 12 steps of the program, not just to be there to listen to the complaints and bitching about how tough life is. Your sponsor is not your bank. It's not your marriage counselor, therapist, doctor. This is not to be confused with working my program. My program, my best thinking got me into this mess. The program is what has worked for others, many worse off than you are. Stick with the winners. Do what has been proven to be successful. The 12-step program has the best documented and longest running success rate of any type of addiction recovery. Addiction is a disease of self-will run riot. You note that self-will means you cannot work my program, which is another example of self. Self-will, it's a terminal selfishness, narcissism, ISM. I, self, me. I am not much, but I'm all I think about. This is one of the most common denominators. Addiction is also a disease of dishonesty to self and to others. Denial. Don't even know I am lying. I could lie to myself so easily about this. I can certainly lie to others about having a disease, about the fact that I think I can stop anytime I want, but yet you haven't yet, despite the numerous problems in your life, directly or indirectly related to this illness, you still use. Dishonesty to others, lies of omission, leaving out pertinent information, lies of commission, active deceit, hiding the truth, hiding your stash, hiding the amount of abuse, hiding the frequency of abuse, minimizing the amount used, denial about outcomes related to the abuse, denial to others and to yourself. How the 12-step program works. Rarely have we seen a person fail who has thoroughly followed our path. Those who do not recover are people who cannot or will not completely give themselves to this simple program, usually men and women who are constitutionally incapable of being honest with themselves. There are such unfortunates. They are not at fault. They seem to have been born that way. They are naturally incapable of grasping and developing a manner of living which demands rigorous honesty. Their chances are less than average. There are those too who suffer from grave emotional and mental disorders, but many of them do recover if they have the capacity to be honest. Our story is to close in a general way, what we used to be like, what happened, and what we are like now. If you decided you want what we have and are willing to go to any lengths to get it, then you are ready to take certain steps. At some of these, we balked. We thought we could find an easier, softer way, but we could not. With all the earnestness at our command, we beg of you to be fearless and thorough from the very start. Some of us have tried to hold on to our old ideas, and the result was nil until we let go absolutely. Remember that we deal with alcohol and drugs, cunning, baffling, powerful, ruthless, and lethal. Without help, it is too much for us. But there is one who has all power. That one is God. May you find him now. Half measures avail us nothing. We stood at the turning point. We asked his protection and care with complete abandon. Many of us exclaimed, "What an order! I can't go through with it." Do not be discouraged. No one among us has been able to maintain anything like perfect adherence to these principles. We are not saints. The point is that we're willing to grow along spiritual lines. The principles we have set down are guides to progress. We claim spiritual progress rather than spiritual perfection. Our description to the alcoholic, the chapter to the agnostic, and our personal adventures before and after make clear three pertinent ideas: that we were alcoholic and could not manage our own lives, that probably no human power could have relieved our alcoholism, and that God could and would if he were sought. The 12 promises of recovery and the 12 rewards of recovery are about the only dishonest part of this program of really rigorous honesty. And the reason they're dishonest because they're so hugely understated. Recovery is, again, it's not about not using. It's about having such a great life that you don't want to use. Imagine being able to attain the peace of mind and relaxation that in the past required using and abusing substances and behaviors, but being able to do so without abusing and to live peacefully in that state forever. The 12 promises. We are going to know a new freedom and a new happiness. We will not regret the past, nor wish to shut the door on it. We will comprehend the word serenity. We will know peace. No matter how far down the scale we have gone, we will see how our experience can benefit others. The feelings of uselessness and self-pity will disappear. We will lose interest in selfish things and gain interest in our fellows. Self-seeking will slip away. Our whole attitude and outlook upon life will change. Fear of people and of economic insecurity will leave us. We will intuitively know how to handle situations which used to baffle us. This intuitively know, this is an inspiration. This is essentially God speaking to us. We can figure out and get out of the situations that used to bog us down and tie us up so badly, and we can do it effortlessly. We will suddenly realize that God is doing for us what we could not do for ourselves. The 12 rewards of recovery: hope instead of desperation, faith instead of despair, courage instead of fear, peace of mind instead of confusion, self-respect instead of self-contempt, self-confidence instead of helplessness, the respect of others instead of their pity and contempt, a clean conscience instead of a sense of guilt, real friendship instead of loneliness, a clean pattern of life instead of a purposeless existence, the love and understanding of our families instead of their doubts and fears, the freedom of a happy life instead of the bondage of addictive obsession. 12-step programs such as Narcotics Anonymous and Alcoholics Anonymous. Addiction encompasses alcohol and all the other drugs that are abused, as well as numerous behaviors. When attending an AA meeting, it's best to introduce yourself as an alcoholic. You may wish to say that drugs were also part of my problem. At an AA meeting, the term addict is generally preferable to alcoholic. Again, the middle of the road term, I'm an alcoholic and drugs are part of my problem, works well in the AA meetings. Crossing the wrong term in the meeting attended may result in some grumbled comments from a member of the group, but if you will recall, the only requirement for membership is a desire to stop drinking or using. We're not in these meetings because we're so healthy, so when somebody complains about a term you used, remember that. We're there because we're not all there. There are a variety of other 12-step meetings. There's meetings for sex and love addicts, Sex and Love Addicts Anonymous, Sex Addicts Anonymous, Overeaters Anonymous, Gamblers Anonymous. There are also meetings for the loved ones of the addicted. These meetings often will end with Anon, Al-Anon, Alateen, Narc-Anon, adult children of alcoholics, and CODA, Codependence Anonymous. Codependence is the term used for those who exhibit enabling behavior. This is a form of behavior meant to be helpful, but in the long run is actually harmful for the alcoholic or the addict. This can be thought of as another expression of addiction. That other person is hooked on the emotional state of the addict. They're very enmeshed and codependent on each other. And an easy example would be the spouse calling in sick for the hungover alcoholic or addict so he or she does not get in trouble at work. The line between helpful and enabling is a very thin line that seems to move over time. It's very helpful to have another person who is not emotionally invested, a sponsor in the Anon program, to help the addict or the loved one of the addict to navigate and determine the best course of action in various aspects of the disease of addiction, codependence, and the interaction with their beloved. I cannot say this enough. There's a lot of people who will go to Narcotics Anonymous meetings and will also go to Narc-Anon, alcoholics who go to AA but also go to Al-Anon, and so on, because remember, addiction is a family disease. We're at these meetings because we're not right. Addicts tend to attract other addicts, so chances are you're attracted to these people. Your spouse may be one of these people. Remember that this is a genetic disease. Your parents or your children may be these people. So you're going to react to how they act. It's normal to react to other people. When your reactions are not healthy, it's nice to have somebody who's not emotionally invested in the relationship to be able to give you a little bit of an additional look, another perspective at how things are going with you and your loved one. These meetings for their loved ones also have their own 12 steps, their own sponsors for the family to work with. In a 12-step meeting, there will be the meeting before and the meeting after the meeting where folks hang out and chat. This is an ideal time to share what's going on in a newcomer's life. It's a great time to discuss problems, concerns, and plans to resolve the issues. The newcomer may come in and share with some of the experienced folks in the group, hey, here's what's going on with me, and here's what I plan to do about it. And of course, it may be an absolutely, totally crazy and off-the-wall solution because remember, we've got our distorted perceptions. We're doing the best we can to make decisions with these distorted perceptions. So after the other people standing around pick themselves up off the ground and stop laughing, then they may be able to give you some truly good advice that you would probably not have thought of any other way. Typically, the longer a person has been sober or clean, the better their overall mental and emotional health is. It's a good idea to attend meetings where there's as much long-term sobriety as possible. Some of these meetings can have hundreds of years of sobriety collectively in each meeting. If you've got 20 attendees with 5 years of sobriety each, that's 100 sober years. Same as 5 attendees with 20 years sobriety each. Ideally, the most long-term sobriety is the one that's preferred. Often there's more long-term sobriety in AA meetings than there will be in NA meetings. That's not an absolute, but it is seen. At the same time, triggers to relapse will be different between the two groups. There will be differences between addictions to various substances and activities. It's best to include the meeting best suited to any given person's predominant addiction, but it might not be a bad idea to dip your toe into some of the other meetings from time to time as well. Many folks have multiple addictions. Remember, if you're an addict and you prefer using, say, heroin, you still cannot safely drink. You can likely cross-addict. Cross-addiction refers to stopping the use of one addiction only to pick up on another. When an addict stops using a certain drug, that does not mean it's okay to use other emotional or mind-altering substances or behaviors. Cross-addicting to another substance or behavior is a very real danger. Even if the opiate addict who hates alcohol can very easily become an alcoholic if they dabble in using alcohol occasionally. Those addiction circuits we talked about earlier in your brain, they're still there. The dopamine feel-good transmitter is still ready to be released in the nucleus accumbens. It's still the final common outcome neurotransmitter for all of these addictive behaviors and substances. Remember that. As important as meetings and sponsorship are, they wouldn't be much good without the full 12 steps of the recovery program. The 12 steps. Step 1. We admitted we were powerless over drugs and alcohol, that our lives had become unmanageable. We. This is a we program. Nobody can get straight alone. We are in this together. Admitted, became aware, realized, recognized, and let it be known to others. Powerless, lack of control or ability to influence. Drugs, alcohol. This is the only mention of substances or behaviors in any of the 12 steps. Remember, use of a substance or behavior is only a symptom of the underlying problem. We ain't right. We need to have our brains washed. The 12 steps are the washing machine for our brains. The abuse is merely a symptom of our disease. Things are unmanageable. We are unable to cope, out of control. Step 2. Came to believe that a power greater than ourselves could restore us to sanity. Came to believe. A power, something supernatural. Back to the spiritual, but let's not call it God just yet. That term drives people who need help away, so let's use another power. That higher power admits to the possibility of something transcendent, even if it's only just the group of drugs or druggies. Restore, to replace what is lost. Sanity, the ability to think and behave in a normal and rational manner. Sound mental health. A trained behavioral scientist in 12-step meetings can make diagnosis of virtually every mental illness imaginable sitting in those rooms if they go to enough meetings. These diseases are all treated differently with medication and types of counseling and therapy, yet they all improve by working the 12-step program. By the same measure, it's impossible to diagnose with certainty any mental illness and the disease of addiction until at least a year of true recovery has happened. This is another miracle of the program. Addiction can manifest as every known form of mental illness. Addiction amplifies and exaggerates these diseases as well. This is yet another example of the distortion caused by addiction. Step 3, made a decision to turn our will and our lives over to the care of God as we understood Him. This is another key concept for recovery. This is very important. Decision, a choice freely made without coercion. Turn our will and our lives. This is also huge. We've surrendered completely. We've given up trying to control our lives for ourselves. We do not know what's in our own best interests. This is acceptance of God's will in our life. The care of God, higher power, understanding that we are under its care, and all that it has care and concern for us, wishing us well, and that no matter how bad things seem to get, it will ultimately be in our best interest. I have what I call the 24-month rule. The worst things in my life that have ever happened to me, within 24 months, I can look at the event and see a bright silver lining to that big dark cloud that came into my life. If you're patient and you just wait, He makes roses bloom out of bullshit. In the 12-step programs, we share our experience, strength, and hope. We don't give advice or direction. My personal experience has been that my higher power, whom I choose to address as God, allows me to go through difficulties in life. Growth often involves pain. We are all made in the image and likeness of God. That is my personal belief. I also believe that these painful events in our life are the hammer, the anvil, and the fire that He uses to forge us in a more perfect example of His image. But He will only do this with our consent and our cooperation. I come out of these difficulties as a much stronger and better person than before the situation that He allowed me to have. My faith is much stronger after such a test. We can choose to violate the decision of His and try to run away from that lesson, but it will find us and probably be repeated a few more times in our lives just to make sure that we've truly learned that particular lesson. It's best to go through it the first time and not run for it. Since we've learned that addiction can mimic all known emotional and mental illness, it can be useful to think of this as one of the many miracles provided by the higher power, whatever you conceive that to be, but the one that you agreed to the existence of in step 2 above. Once we truly decide to turn ourselves over, the miracles of the promises begin. The miracles will continue as long as the program is practiced and shared with others. Not my program, but the program. Step 4, made a searching and fearless moral inventory of ourselves. This is the first action step. It involves pen and paper or keyboard. It will take a lot of time, work, reflection, and help from a good sponsor. Sometimes a good therapist may also be helpful or required. This involves a very thorough and complete moral inventory. Remember to get the good as well as the bad. Not just what you did right or wrong, but why you did so. That's where the therapist may come in. Certainly a good sponsor will help with that. This is more about the simple wrongdoing. It's about the underlying reason on why the wrongdoing happened. Without being completely thorough and honest on this step, future relapse is likely. This will also form the basis for the 8th and the 9th. Step 5, admitted to God, to ourselves, and to another human being the exact nature of our wrongs. God, it's okay to use higher power if preferred. Another human being, it's essential to communicate this information derived from step 4 to another person. Often, but not necessarily your sponsor. Ideally, often the other person, perhaps your sponsor, will share similar issues and experiences with the person doing the step, known as the sponsee. The exact nature involves not only the wrongdoing, but the underlying reason and motive behind it. Step 6, we're entirely ready to have God remove all these defects of character. The higher power from steps 2 and 3 is the source of this healing, restoration to sanity and revocation of mental illness. The compulsion to drink may be lifted with step 3, sometimes persistent longer, so it may resolve after step 6. Entirely ready means without reservations, no matter what may come. God, the higher power, removes these defects, but only with our unreserved consent and cooperation. Defects, faults, failures. Character, our most basic moral character. Step 7, humbly ask Him to remove our shortcomings. When you have nowhere else to turn and are on your knees, turning to your higher power, you are at your strongest. This is done with the humble realization that we have not been able to heal ourselves. We admitted that our issues have been our shortcomings. Step 8, made a list of all persons we had harmed and became willing to make amends to them all. After having done step number 4 with the realization of the harms done by our moral failings and faults, it's now time to start contemplating being able to make appropriate amends, and to whom. This also requires review with a good sponsor. It's not about apologizing, it's about making amends, and it's about becoming ready and willing to do so. Made, this is another action step. A list of all persons, everybody, and the list will include second-generation harms. We may have caused some harm to somebody who in turn caused to another after what we did to them. Became willing, in part because of having done the fifth step, willing to make amends to them all. Step 9. Made direct amends to such people whenever possible, except when to do so would injure them or others. Amend, to make better or improve. The U.S. Constitution has 27 amendments. Not one of them starts with an apology. Imagine driving a huge railroad spike into the middle of an expensive polished mahogany conference table. An apology would entail removing the spike, leaving a large hole. An amend is to fix the table in a manner satisfactory to the owner of the table. Except when to do so would involve injury to them or especially to others. You do not want to injure other people. An example would be undiscovered fidelity. If you insist on the cheater to go back to their spouse who is ignorant of the affair and tell them what had happened, this would just breach distrust in the relationship. If the victim of the spouse who is ignorant of the wrongdoing, it's best not to expose and cause pain. If there has truly been a change, the future transgressions are quite unlikely. Now, if this change has not happened, give it time, and hopefully with growth it will improve. The amends process is to heal you, not the other person. It releases you from a spiritual bondage, a form of guilt toward that other person. Step 10, continue to take personal inventory, and when we were wrong, promptly admitted it. Continued means that this is an ongoing process, often done at the end of each day with a daily review or reflection, especially regarding any problems that may have occurred and how they were responded to. When we were wrong, recognized we'd committed a transgression, promptly admitted it without delay, and made amends as soon as possible. Step 11, sought through prayer and meditation to improve our conscious contact with God as we understood Him, praying only for knowledge of His will for us and the power to carry that out. Sought, we continue daily to pursue our higher power in whom we've entrusted ourselves without reserve. Prayer and meditation. This is not medication, this is meditation. Prayer can be thought of as transmission upward and upload of sorts to our higher power. Meditation is our reception, our download from the higher power. Improve our conscious contact acknowledges that we have to have conscious contact with our higher power. This is the essence of spirituality. We improve on a regular basis. It is a skill. It gets better with time. As we understood Him, remember, this is our own personal higher power that we chose in steps 2 and 3. The same one we turned our lives over to, the same one we chose to heal us, the same one who removed our shortcomings, including our compulsion to use, and who gave us the gift of recovery. Knowledge of His will for us. We are only to pray for that which He wants for us. We turned ourselves over to Him in step 3. This reinforces that decision. We acknowledge that He alone knows what is best for us and the power to carry that out. He alone gives us the power to do His will. He will provide us with the power to do His will. He is the miracle department. He has better plans for our life than we have for our own lives. Step 12. Having had a spiritual awakening as a result of these steps, we tried to carry this message to alcoholics and to practice these principles in all our affairs. We have already. It's a done deal. There is no more doubt about it being possible. It's an established fact by now. Spiritual awakening, established and continue to enhance and maintain our relationship with the transcendent, my higher power. Perhaps it is God, whatever you call Him. While many agnostics enter the 12-step programs, within 5 years, few of these folks continue to describe themselves as agnostic. Faith grows. Result of these steps. Clearly, this is the outcome. of all the work we have done to date and our sacrifice of self in step 3 to our higher power's will. Carry this message, carry, to maintain with me and myself and to convey to others. This message, the gift of recovery, the steps, the meetings, sponsorship, service work, fellowship, to anybody and everybody who wants it. This program is for those who want it, not for those who need it. We ourselves are living proof of this. We cannot demand anybody into this program. We can, however, command wordlessly people come into this program merely by our presence and our actions. Somebody with good recovery has a certain attractiveness to them. People recognize this. They don't explain it, they don't understand it, they can't put their finger on it, but they just know that there's something about a person in good recovery, and they tend to want to hang around. Therefore, the newcomer is the most important person in any meeting in this program, and in any meeting in the rooms as well. We have to give it away. We can't keep what we do not share. We cannot share without the newcomer. The newcomer is the most important person in any meeting. Therefore, you must continue this hospitality. Practice these principles in all of our affairs. We practice these daily. This is what we do. These principles are the 12-step program in all of our affairs. We don't pick and choose. This is our new way of life. Likely much different from our former way of life. The pillars of the 12-step programs: self. We alone are responsible for our actions. Society, fellowship. We stand together and strive to interact with society at large. God, our higher power, the source of this miracle of our recovery. Service. Work to help each other. Freedom. The lifelong process of healing and growth. Goodwill toward others to promote recovery. Unity, we work together. Service provided to each other. Recovery, growth, both collectively as a whole and individually. It's a circle, it's a global. A few comments and meditations on the concept of relapse. There are no accidental relapses. They are always planned, consciously or subconsciously. You must remain vigilant against them. Beware of a surprise addiction attack. Remember, this is the power of evil that we deal with. This usually comes in the form of relaxing the intensity with which you work the, not your, program. Meeting makers make it. You can't save your ass and your face at the same time. If you relapse, you must make it known and you must start over. This is a disease that is cunning, baffling, powerful, ruthless, and lethal. The outcome is certain, but only after numerous chances to save your ass and perhaps brief life of utter misery. Jails, institutions, and death. You don't want to be fitted for a body bag or sport a toe tag. The promises of relapse. Number 1, if we were casual with this phase of our development, we will be using before we are halfway through. We're going to know a new imprisonment and a new misery. We will relive the past and won't be able to shut the door on it. We will comprehend the word conflict and we will know pain. No matter how far down the scale we have gone, we'll sink even lower. That feeling of uselessness and self-pity will deepen. We will gain interest in selfish things and lose interest in our fellows. Our whole attitude and outlook upon life will suck. Fear of people and of economic insecurity will multiply. We will intuitively know how to run from situations which never used to bother us. We will suddenly realize that God would have never done to us what we are doing to ourselves. Are these extravagant promises? We think not. They are being fulfilled among us. Some of us, those of us who are still using, sometimes quickly, sometimes slowly. They will always materialize if we use for them. Thank you for your time.